Hi, everyone. Good afternoon. I hope everyone's doing well. It is exactly 2 o'clock, so we're going to go ahead and jump in with today's installment of the His Health webinar series. We are excited to be featuring our partners again in Memphis, Tennessee at the Connect to Protect program. Today's topic for discussion is mobilizing the community to remove policy and programmatic barriers impeding care access for young Black MSM living with HIV. Our webinar today will be led by Andrea Stubbs, who is the manager of HIV community programs at St. Jude Children's Research Hospital in Memphis, Tennessee. Andrea works specifically in the infectious diseases division at St. Jude's, where she has served as a behavioral health specialist implementing youth-based interventions among minority patients. A particular interest today is Andrea's work with helming and leading the C2P, or Connect to Protect program. The Connect to Protect program is a community coalition located in Memphis, Tennessee, that is made up of a cohort of stakeholders that are working in public health at local and state health departments, as well as in other sectors outside of health, like faith-based communities and schools. And this cohort works together to address social and structural barriers to care experienced by Black same-gender loving men and adolescents living with HIV. So we're so excited to have Andrea join. And I'm going to move over to the next slide. And so a little bit about our agenda today. Hey, Andrea. How's it going? She's here. So for our agenda today, we're going to do a little bit more of a background and overview about the Connect to Protect, or CTP program, and how it operationalizes in Memphis, Tennessee. Andrea will also delve into discussing some of the impact of addressing the structural changes that are necessary to improve the standard of care for Black gay men, and she'll also highlight the C2P and SMILE Strategic Multi-Site Initiative for Linkage and Engagement for Young MSM living with HIV. I think I got it. Woohoo! She'll talk a little bit about that, the symbiosis between those two entities and how their collaboration translates into great health outcomes for Black gay men living in Memphis. She'll also talk about some of the challenges and the problem-solving efforts and strategies used to address some of those issues, and then talk about the impact of the community's mobilization work to remove these barriers. So without further ado, I'm going to pass the mic over to you, Andrea. Take it away.
All right. Thank you so much for having me to come talk again. This has been a great partnership, and I'd just like to thank you all for having us and to just really talk about our efforts to improve health outcomes of young Black gay men in our community. We found nothing but value in working with CBAC and NASDAD, and we cannot wait to glean more knowledge from all of the upcoming webinars, and especially to be able to see the His Health website when it is complete. I'd also like to take this time to acknowledge our colleagues here at St. Jude Children's Research Hospital at our HIV clinic. These are some of the smartest and most diligent scientists and clinicians and caring people I've ever met and have had the privilege of working with. I'd also like to acknowledge that C2P and SMILE, the research platforms that have allowed us to successfully link Black gay men to care, are part of a national Institutes of Health-funded adolescents medical trial, medicines trials network that for almost 2 decades has allowed for the creation of a community-level coalition of various stakeholders that you spoke of, Amaro, that share in common the mission of improving HIV prevention and care amongst youth. And I have to say that C2P is the largest national community-based research study of its kind. And we can go to the next slide, please. Our community coalition and SMILE programs are housed at out of St. Jude Children's Research Hospital in Memphis, Tennessee. Memphis is located on the bluff of the mighty Mississippi and have for many years been known for defining moments in history, great food, and great music. On the contrary, our city looks like an impoverished country. There are certain populations that are surrounded by poverty, have limited access to healthcare services, limited education, and high disease rates amongst those communities, and especially communities of color, our Black and brown brothers and sisters. And this slide is just a snapshot of the HIV incidence rates in Memphis and Shelby County, and this is taken from our HIV/AIDS and STD annual surveillance data from 2013. What we see here is that the Memphis Metropolitan Statistical Area, or MSA, is disproportionately impacted by high rates of HIV among Blacks where blacks only make up about 52% of the population here in Memphis, but we account for 81% of almost 11,000 cumulative cases within our city. We in Memphis are ranked 7th in the nation amongst all MSAs in HIV incidents, and there were a total of 322 in this particular year of new HIV disease, and the majority of these cases occurred in African American males. These were reported to be most commonly transmitted through MSM behavior and occurs most often in 15 to 34-year-olds. I'd also like to add, and I did not include it on this slide, but in a previous slide, is that Memphis has some of the highest chlamydia, gonorrhea, and primary and secondary syphilis rates in the nation, especially among our 15 to 19-year-old population. Next slide, please. The Connect to Protect intervention, the umbrella by which we operate and implement community-based changes, is a multi-site community research study supported by the Adolescence Trials Network. It was initiated in 2002, implemented in 14 urban communities, up through the year of 2016. The ultimate goal of C2P is to reduce HIV incidence and prevalence among young youth ages 12 to 24 years old through community mobilization and structural changes. That said, it is up to the coalitions locally to identify the issues that are fueling risk among youth in their communities, and you are encouraged to come up with solutions or structural change objectives, and that would be any new policies, new practices, or programs to address those issues. So what is the C2P intervention? The intervention itself focuses on coalition building and strategic planning and those structural changes that bring about the new programs, policies, or practices. There is a geographic area of focus that each coalition works on, and then there is a primary population of focus that each coalition addresses. The way in which we work as a coalition is to define the relevant problem or challenge or root cause, perform a root cause analysis of that challenge, identify structures or systems or policies that are worthy of targeting to attain that necessary change that may be necessary to help reduce the acquisition and transmission of HIV. We are instructed to operate within a broad research framework with some requirements in place to meet grant-funded objectives. However, these activities contribute to the necessary relationship building that's needed to foster a shared responsibility and get that necessary buy-in towards the changes that we're wanting to implement. Examples of some of the requirements are to hold regular working group meetings, to focus on HIV and a subpopulation of youth, to develop and to pursue structural changes as a catalyst for change, not implementers, and to complete a biannual coalition survey and in-depth review of our strategic plan. We also work on our own coalition's infrastructure, and we decide how we would develop the structure and operating procedures based off of the community needs. As a supportive component of the Adolescence Trials Grant, from which C2P is housed, there's an auxiliary support group called the National Coordinating Center that provides or that has provided technical assistance, including resources or tools and guidance, and this has been very helpful as we progress through various meetings and various time points within the coalition in trying to implement various changes, because insights and activities from the other 13 or so coalitions across the country are shared amongst us, and it helps with sort of trying to steer or direct some of our thoughts or our comments, especially if communities resemble. We also receive in real time a visual representation of our progress, which is very helpful for individuals who are not research savvy to be able to see that progress is actually happening. Next slide, please. Connect to Protect was launched in 2008 with approximately 22 consistent members representing AIDS service organizations, local government, faith-based and social service organizations. The target geographical area of focus is Memphis, Shelby County. The target population would be youth and young adults ages 13 to 24 years old. And the vision is to reduce new HIV infections in Memphis' most vulnerable youth. And just honing in just a little bit on our targeted population, when we began the coalition and began meeting, we had to be very specific about identifying a target. Would we focus on young women who would have sex with men, or would we focus on men who have sex with men? And at that time, we saw the epidemic some almost 10 years ago looking a little bit different than what it looks like now. There were more women identified in our community at that time. We had more access at that time, and probably could talk about young women having sex with men a little bit more palatable than talking about young men having sex with men here in the South, in our Bible Belt. But over time, we began to see the trends, the national trends, catch up to what our community was actually looking like. And most of the objectives and the community initiatives have always had collateral benefit. However, over the last 5 or so years, we've seen our focus sort of hone in on young Black gay men, and our efforts and our objectives were speaking directly to how could we do more to test, link, and to provide preventive service for this population. Next slide, please. The mission of our coalition is to mobilize allied community resources and to execute an aggressive prevention strategy to reduce the rate of HIV and AIDS amongst at-risk youth and young adults ages 13 to 24 years old through advocacy, awareness, and evidence-based interventions in Memphis and surrounding communities. We take a collaborative approach between the CTP coordinators and the community coalition members to dissect structural determinants of HIV prevention along the continuum of care and develop solutions such as those SEOs to address barriers. Our current partnerships includes, and I spoke about this previously, a diverse mix of power brokers. And that would include some local and state health department representatives, individuals who are affiliated with federally qualified health centers, individuals who represent AIDS service organizations, community-based organizations, must also say faith-based organizations. We have representation from grassroots organizations, from colleges and universities, some of our professors who have a specific research focus on HIV, and as well as our local school system. Next slide, please. As noted, CTP was conceptualized to focus on the structural level factors. While structural change is not new to public health, it had very limited application in the field of HIV prevention at the time that we launched our program. This approach really required coalition members to think about contributors of HIV risk and solutions in an entirely different way. Although the capacity to do structural change was a significant process, it certainly paid dividends because we now have a cadre of community members with an ongoing capacity building, I must say, that are well-versed, believe in and promote this approach of structural level interventions that contributes to a decrease in HIV acquisition and transmission. Next slide, please. This is the CTP Logic Model, which is used as a planning tool to help our coalitions focus on the ultimate outcome of reducing incidence and prevalence of HIV within our targeted population. Community mobilization represents the intervention on the left, which leads to the development and implementation of structural changes. In order to develop the structural change objectives, our community partners are encouraged to think deeply and broadly about HIV risk in youth. A significant amount of time is devoted to dissecting the underlying structural determinants of risk in our community, and then discussing how those risks are linked to those core risk factors, as you see in the middle column. So you can imagine that our objectives are approximately related to these core risk factors. Many of the coalition's objectives were often distantly related, such as housing instability or mental health. And in the case of the HIV care continuum, our coalition SEOs remove barriers that hinder seamless youth linkage, engagement, and retention into care. And I'll actually do an example of that a little later on in the presentation. In the end, we ensure that our efforts are logically linked to the primary pathways of HIV transmission and acquisition. Next slide, please. This is a summary of the coalition's successes over the years. The graph shows a growth in where we are in terms of these various variables. First, we can see that there have been 398 community actions, which are inclusive of our meetings, strategic planning efforts, and action steps that have been accomplished along the way. 95 new key actors or people have participated and contributed to bringing about these action steps to support our objectives. We have been able to accomplish 52 new structural change objectives, those new policies, those new practices or programs in our community that target issues or barriers that impact youth, and especially Black gay men. Mobilization efforts in the Memphis community will continue as we see value in being sustained beyond our ATN funding that unfortunately ended in February 2016. The continuance is due mainly in part to the successful outcomes along the care continuum and the number of changes that have occurred within our community. The coalition felt that we were just on the cusp of doing greater things within our community and wanted to continue to meet and figure out ways to sustain our efforts so that we would be able to be more impactful as the years continue to roll on. Next slide, please. We also have our Youth Linkage to Care program we call the SMILE program, the Strategic Multi-Site Initiative for the Identification, Linkage, and Engagement in Care program, a mouthful, or our SMILE program. It was launched in 2010. Really, it has a goal of identifying all HIV-positive youth in Memphis and linking them to medical care. We all understand that for the longest time, there was a push to increase screening and testing within certain communities. However, we found that testing, though important, left a large number of individuals that were not following up with or assessing medical care. A huge gap was identified in that there was no effective means to link newly diagnosed individuals to care, meaning as testers, we were not actualizing the full public health benefits of testing when we failed to link an infected person to care. This program really helps to bridge the gap between public health and health care. In Memphis, this is a local partnership between St. Jude Children's Research Hospital and our local health department that has been quite beneficial and successful over the last 5 to 6 years. While this is still a national program like CTP, the local partnerships contribute to the success of the program. I must also point out that we have a dedicated case manager or adolescent outreach expert, our SMILE Linkage to Care coordinator, who provides seamless linkage and interaction with these newly diagnosed youth almost on a 24-hour basis. It is very intensive, it is very interactive, but it has proved to be very beneficial through this process of linking these newly diagnosed youth to care. Next slide, please. Through this collaboration, here are some of the accomplishments we've been able to attain over the last 5 to 6 years. We were able to successfully begin the linkage process for 655 newly HIV-positive youth. This averaged to be about 10 new referrals per month. Of those that were referred, we had 78% of those that were linked to care. Of the 78% that were linked to care, we had 96% of those that were engaged in care. And of those that were engaged in care, 90% were retained in care. And this work also, sadly, the funding will not continue beyond February of this year. However, we are continuing to do this work as we speak, and we see value in being able to provide this intensive case management beyond the grant funding just because of the tangible outcomes that we've seen. Our clinic population here alone at St. Jude has increased by well over 50% just from having this very intense one-on-one interaction with a newly diagnosed youth. And for those individuals that are not coming to our clinic, we have just as many who are other of our community partners who are whether they're private physicians or at some of the other care facilities that have also seen a benefit of having this linkage to care process. Next slide, please. With the launch of SMILE, the SMILE program, we worked to integrate a linkage to care component within our coalition's strategic plan. And this was to ensure that the youth barriers along the HIV care continuum that were identified through the SMILE were appropriately addressed. In 2011, right after the launch of the SMILE program, our coalition formalized a Linkage to Care subcommittee that had efforts dedicated to addressing youth barriers along the HIV care continuum. There are approximately 11 active participants in that subcommittee, and it is chaired by the SMILE Outreach Coordinator, who is directly responsible for the intensive case management and linkage to care. Other individuals that serve on that subcommittee are key staff or key stakeholders who benefit from the linkage at the other care facilities, as well as our local health department, who has given us public health authority to be able to cut down the amount of time that it takes to interact or locate some of the individuals that are newly diagnosed by giving us access to public health information. And so many of the key players are a part of the planning, part of the process, and are part of the solutions for those barriers that are brought to the table. SMILE data presentations are standing agenda items on the C2P working group meetings, so that our members are kept abreast. We also offer ongoing capacity building activities with coalitions, just again to bring in that aspect because as you've seen, our coalitions initially focused on prevention, on the prevention side of things, and we saw this as a way to further support prevention efforts on our targeted populations. Coalition members also worked very closely with the SMILE coordinator, and often inviting her to participate in testing and outreach events. And this is a great benefit to the work that occurs with testing and linkage. This allows for an opportunity of direct, immediate access to someone who can begin the linkage process immediately after you are told that you may have HIV. And so it builds the rapport early, and we've seen the success of it often in our clinics and in our other partners' clinics as well. Next slide, please. Of these efforts, you can see that there have been 42 structural change objectives initiated to date. 69% of those have been completed. Many others are ongoing, and new ones are being added each week or as barriers are brought back. This is also showing you the breakout of these SEOs by different intervals. We have 31% of our SEOs that addressed barriers to HIV testing and diagnosis, 62% of our SEOs are targeting linkage to care outcomes, and 7% of our structural change objectives are targeting engagement and retention into care. And while we don't have any that are directly addressing viral loads, it's definitely something that is priority in the long term. We have began or initiated SEOs that are that actually assist individuals with coping. Some SEOs are related to social support groups, psychosocial support groups, and mental health aspects of those things that may come as a result of trying to really come to terms with the new diagnosis that we believe also contribute to individuals falling out of care. We'd like to provide housing and transportation for everyone, but we know that that macro level challenge is a big one to really accomplish, but we are working on trying to figure out ways to help individuals become, have a place that's safe to live so that they can then focus on their health. And so we see those as being some that will be completed within the near future, and we believe that that will help keep individuals in care longer, not fall out of care, and hopefully attain that viral suppression. Next slide, please. Now what I'd like to do is spend a little bit of time talking through a couple of scenarios to help you to see the process of addressing the barriers and how it unfolds. This is a typical scenario that our Linkage to Care coordinator confronted, and this is how it was brought back to the working group meeting for discussion and root cause analysis. We have a 22-year-old man who has sex with man referred to the SMILE program by his partner. Typically, we will have new patients come into our clinic or other clinic, and we ask them to bring any support that they may have. And so often this translates into our newly diagnosed individuals bringing their partners in. And we don't just tend to the needs of that individual who is newly diagnosed, but we also try to provide the education for that supportive system. And as a part of that, we will offer or have some of our community partners come and offer testing as one of the supportive tools. So this individual reported doing well. After being tested, he was diagnosed with HIV infection as well as syphilis. He was referred to the health department as a first step toward linking him to medical care. The barriers that were identified really were at our local health department, and these were policies that were exclusive to our health department in needing the confirmatory testing results. An individual could not receive their confirmatory testing results without a state-issued ID. Also, an individual would not be able to become Ryan White certified in order to receive the necessary insurance information related to paperwork. It could not be completed without the ID, and it could also not be completed without certain steps in place. Next slide, please. So those are barriers that were identified. The solution would be through our root cause analysis. This barrier was brought back to the coalition. We saw it through several patients. It was affecting the linkage time by more than, it typically takes from the moment today, I would say it would take about 2 weeks to link someone into care. A worst case scenario, it would take about 5 weeks to get someone to that first medical appointment of what we call or consider linkage to care. But this particular scenario or barrier was causing individuals to be out of care in excess of about 3 to 6 months. And so we found this to be a challenge, especially with the youth and young adult population that we work with who are very transient. The phone numbers change quite frequently. We also know that the addresses are not always good addresses. We know that individuals are sometimes homeless but don't consider themselves homeless. They do this couch surfing here where they're staying with a friend one week, maybe with a grandmother or relatives the next week, and just going from location to location. And so we felt like 3 months was too long to get to that first medical appointment. Individuals would easily become lost or lose interest, especially if there were no physical signs of HIV. If they were not feeling sick, then it would not become a priority, and we wanted to capitalize off of the initial interactions or first interactions that we've had or first encounters with those who are newly diagnosed. So our solution, through our brainstorming and through our root cause analysis that was brought back to the coalition, is that we would work to remove the existing barrier of requiring a state-issue ID, such as a driver's license, to do confirmatory HIV testing and complete the Ryan White certification-related paperwork. Through our series of But Whys, we asked why was a state-issue ID the only and necessary form of identification that could be used in order to get a confirmatory HIV test. We asked health department personnel who were sitting at the table, could there be other considerations to receive a confirmatory test? Could we not put up, or could they not develop, or would they not consider developing a new process or a new policy that will allow individuals who, even though they were 18, who maybe did not have state issue ID for several different reasons. So we've often asked some of our youth why they didn't have a state-issued ID. Some said that, you know, they could actually be robbed and their ID would be stolen anyway, and so it's just best not to have one. And frankly, some just actually reported that they had not thought about that it was necessary to have a state-issued ID or driver's license, even to the age of 20 or 23. And so the SCOs, or the new policy, practice, or program that was proposed, was that the Shelby County Health Department would modify policies to accept alternate identifiers from individuals seeking test results. And those key actors that would be involved would be Shelby County Health Department managing staff, the surveillance staff, also the medical case managers, who would actually complete some of the Ryan White paperwork, and the clinic nurse managers, who were often the first line to do the blood draws and often conduct the STD testing and provide some of the confirmatory test results. This process included several discussions and several, I think, plans that the health department will feel comfortable with adopting in order to meet the needs of the community that we're presenting with not having enough information. Next slide, please. The second problem, all preliminary positives were required to obtain verification of Ryan White medical care services from the Shelby County Health Department before services were rendered. There were two new policies that were proposed and implemented that will reduce the lag time between the preliminary positive and initial appointment by allowing others, such as youth adult service providers, to verify eligibility. And this process just it was very simple to really address. I think the biggest challenge was just having the discussion or even pointing out that it was a barrier. Once the problem was identified, it was brought to those individuals that provide the training to just simply start to train other youth service or adult service organizations on the process of verifying Ryan White, and allowing those agencies to provide or to go through and do their own verification and eligibility, along with the still following in line with what Ryan White requires within our community. And I can look back on this now and say that this process, or even looking at these slides, could possibly indicate that this process was very easy, that it only took about a week to accomplish, when really it took, I think, close to about 6 months or maybe even a little bit longer to just talk about how to move forward and to get the buy-in and support from all of the key actors that will be involved with changing the new policies or the new practices and the new programs, and to make sure that all key actors would be trained appropriately and that there would be the seamless coordination from one agency to the next. Our health department is the largest testing entity in our community, and often we have smaller agencies that provide testing. However, because of how the health department will provide services, especially for confirmatory testing, each person that's tested will have to eventually go through the health department. And we felt like because they were the largest entity, it would be best to consider changing the practices or the policies and the programs at the health department side in order to facilitate a more cohesive linkage process for our youth. And we've seen much success with this. We now have been able to streamline that process and get individuals into care, depending on where they go, as little as a week to 2 weeks at certain organizations or certain care facilities, and no longer than about 4 to 5 or maybe 6 weeks at the max, which still falls within a good linkage time according to the parameters for our SMILE Linkage to Care program. I think the other things that were beneficial to being able to accomplish these barriers is having all the key players at the table during our coalition meetings. I mentioned that we have 22 to 25 active participants when we meet every other month. And at that time, you can hear different updates, different subcommittee reports, and especially the subcommittee report that focuses in on linkage to care barriers. And the barriers are then brought up and addressed, and we can have the key players there to talk about and to begin to think about and strategize how the policy could be implemented at the home front and how the practices could be implemented at those agency sites, and who would be needed in order to make these things happen. Of course, we didn't just leave it up to the agency to come up with this on their own, but it was through the strategic root cause analysis that we identified the process of who, how, what, when, and what people would need to be in place in order to make these things come about. Next slide, please. Some bright spots and lessons learned. Our local HIV prevention planning councils serve as a catalyst in shifting the HIV epidemic among Black gay men. We know that our successful linkage and engagement of Black men who have sex with men into care began long before we had dedicated staff to provide intensive case management through our SMILE program. We found value in developing and mobilizing a community-based coalition that contributed and resulted in changes to the environment. These changes have led to a reduction in health and other social problems of HIV-infected young Black gay men. Further, these policy adjustments have therein resulted in better engagement of young Black gay men into continued HIV care and engaged treatment and care at our facility, as well as private providers and other institutions within Memphis that they choose to go to. Convening a group with shared ideas and individual resources was a value add to all of our success. Our meetings and trainings and planning allow for the breakdown of silos within communities, and often enabled us to address cultural humility while simultaneously addressing agency and individual biases that exist amongst everyone who is a key player at the table. Pooling our resources also improved youth HIV linkage to care. Many of the key testing agencies were already invested in the coalition and could actively participate in real-time discussions on those barriers that were brought back. Agencies were able to speak candidly about their limitations and participate in the intricate process of root cause analysis and strategic partnering to develop stronger allies at those agencies, and also to develop a plan or a process to be able to take back to those top leaders or key leaders that will ultimately be responsible for making the policy and practice change. The capacity building that has been offered during coalition meetings has facilitated a safe space for addressing things such as stigma and discrimination in Black communities. These topics often organically came about as the barriers are brought forward or addressed, or the community norms and issues are discussed within our coalitions themselves. However, there's also thoughtful planning for capacity building training as information is gathered through the coalition health and functioning surveys that are given twice a year or so to the coalition members. It is an anonymous survey where there are some structured or general questions that are asked about the purpose of the coalition. Are our processes and objectives clear? Are we focusing on the right population itself? Should we or do we need to modify our vision and mission? How do we refine some of our practices? But there is also room to write in where coalition members have more thoughtful suggestions, ideas, or concepts, or just an opinion about the direction in which we should go. I must point out that this is a community-led coalition simply facilitated by a community coordinator who serves as that person to sort of bring everyone together in a neutral space to discuss some of the challenges that exist within our communities around HIV acquisition and transmission. And it serves as a place where we can healthily discuss and tear down some of the communication barriers that may exist amongst organizations, some of the things that wouldn't ordinarily be discussed by working in an individual silo. And additionally, a lesson learned was that shifting the HIV epidemic among Black gay men is a shared responsibility. As I mentioned, the coalition is made up of a diverse group of individuals, from content experts at universities to governmental agencies, those community-based organizations, the faith-based organizations, the grassroots organizations, all of which have a specialty and a mastery. However, what we have learned is that no matter how focused or specialized we are in one area, such as having the infrastructure to bring research to a particular community, it does not carry as much weight if we do not have access or buy-in to those community individuals, such as that access that is given to us through some of the grassroots movements that are occurring. Our success as an individual agency will only be marginal compared to us collectively coming together to work through some of the challenges or some of the barriers or some of the hurdles that we incur trying to accomplish our objectives and our goals, I guess as an individual organization or an individual entity. Each of the organizations within the coalition has learned to embrace and respect the assets contained within each agency and or the individual representatives. And most individuals find that statement that I just made very hard to digest, considering that we are in the faith base or we in the Bible Belt of the South. But we've seen it work through careful attention to and respect for each organization that's represented. There's a way for faith-based to exist in a space with an agency that is open to more than just abstinence or abstinence only as their primary prevention for contracting STDs and HIV. We have been able to collectively plan various national observance days, conferences, and be able to have an arm that is conducive for all of those that attend. So if you're on a research track, we will have an arm for that. We will also have some space or teaching for individuals within the faith community, and we will also have some that are for individuals of the targeted population, as well as those who may need a little bit more capacity building Living or agencies that are community-based or medical care or service providers. And because we understand that we're not just dealing with an individual level problem, but if we wanted to address the structural level problems, we'd have to address it from various angles, which is our whole purpose of having so many different sectors represented within the coalition and so many different individuals also represented and respected within the coalition. And finally, something that I view as a bright spot and lesson to be learned is that cultivating community relationships definitely takes time. Relationship building goes beyond the quarterly gatherings that occur with our working group meetings, but it occurs more during the off months of meetings when an organization calls the community coordinator to assist with planning a conference or needing staff training or to build capacity within a staff or technical assistance or needing an extra hand to assist with community testing that may occur in the very, very hot and humid streets of Memphis in the dead of summer. We answer most always with a yes. And that yes and yes again often builds that trust, that camaraderie and support that is worth more than any gesture that will come from just a lunch or a trinket with a branded logo on it. We realize that our success within the coalition, which leads to success with other community-based research, especially with our SMILE outreach research that has been very successful with linking young Black gay men into care, it comes with this gentle balance of bartering of sorts. In fact, it's the premise for which we believe that the buy-in and support are built from all the key stakeholders that represent or participate within the community coalition, and we see value in continuing to do lots of that work. Just because not everyone is a master of everything, like I pointed out, but you can bring your strengths to the coalition and be able to help to bring individuals that may not have as much knowledge or insight into a particular subject matter up to a level that they can be comfortable enough to allow change to occur or to accept a new practice or a new policy to occur within their respective organization. And the next slide, please. Oh, wow. I didn't realize I was finished. I'm so sorry. I guess I could have talked on and on. But I'd like to just thank you all very much for taking the time to listen to the great work that we're doing here in Memphis and Shelby County and our surrounding communities to link our young Black men into care, and what we're hoping to be able to really see the needle on these number of youth and young adults that are infected with HIV go down over the next few years as we continue the very hard work within our coalition infrastructure, as well as continue the very hard work of this intensive case management for these youth and young adults who are newly diagnosed HIV positive. And we get nothing but great feedback from these youth saying that they appreciate and they do value having someone involved early in those first weeks of being diagnosed and helping them to navigate what could be an overwhelming and intimidating process. Thank you so much.
Right. Andrea, thank you so much for another really rich, robust, and engaging conversation. At this time, we're taking Q&A. We've been gathering some as we go. There's a little chat function in the bottom on WebEx that says Q&A, so feel free to enter in your questions. And, Andrea, we have some already here for you. There's one. Hey, all right, so you're ready. Okay. So there's a participant that had a question about the SMILE program, and they want to know what happens when patients graduate from the SMILE program, because there is that age cap of, I believe you said 24?
I think that's an excellent question, and it's definitely something that our clinic has worked on for many, many years, having a transition plan when patients age out of the program. So the SMILE is broken into several intervals through the intensive case management, there's a linkage piece that occurs for a phase of time, and then there's the engagement piece that occurs for a phase of time, and then there's the retention and care that is occurring, but it's more of we are helping you to become a little bit more self-sufficient, and so we are passing you along with still engaged with, still keeping our eyes on your activity and how you matriculate through your care, but that responsibility then becomes that of the clinic provider, the social work team, or wherever the service is being handled. And so there's not a lot of hand-holding that happens within the retention and care phase. However, when patients do age out of our clinic, we do have partnerships, and we have them at the table as well. But we do have partnerships with some of our adult specialized clinics to help them, to help facilitate the transition. We have been getting lots of feedback from some of our adult providers saying that you spoil them too much at St. Jude, and we realize that. And so we're starting to revise and refine our transition plan just a little bit so that we can make sure that our patients that leave us are actually staying in care and maintaining their health so that they can achieve viral suppression. But it's been very good to go and assess the program and to speak with our community partners, especially those clinical care facilities that are part of the coalition and that can come back and say, here's where we'd like to see you modify your transition plan. Here are some of the challenges that we're seeing with some of the patients that age out of care because they're young adults, so not full-on adults and still not quite vested in their health 100%. And so we're working very closely with our clinic care providers to help our youth become self-sufficient and ultimately maintain that viral suppression.
Awesome. Couple of questions around sort of how to gain community buy-in and kind of a question around interpersonal relationships. We have a participant who says that often when we're talking about HIV transmission, sex is sort of intrinsically linked. And what was your experience in trying to engage sort of faith-based organizations, of some of which may have a bit of a tenuous relationship, talking about hetero or homo or any other sort of normative sex? How did you sort of deal with anyone who kind of presented with a hate the sin, love the sinner sort of complex, but you both want the same thing, which is a reduction in or HIV or better HIV management in the community?
Yeah, so I think that's excellent, and we definitely encountered that early on in the process. We spent one entire year completely on relationship building, and with that, we noticed that some of that tension was coming out. There were sectors that did not want to place well with faith, and there were faiths who probably would not admit this, but were not as comfortable playing with some of the other players that were at the table. And so part of the strategic process and the beauty of being connected with other community coalitions across the state was sort of strategize with some of my sister sites and talk about if they had encountered some of the same type of challenges. And because I had access to certain community groups and community individuals, it was my discretion to bring in a community advocate who would build the capacity on both levels. So there were experts who were pastors, but also who had ministries devoted to HIV and AIDS. And so that was palatable to the faith community. And then there were experts who were strictly community or working for agencies that provided long-term, long-acting birth control, but also had a faith component to their agency. And so I would bring in those different content experts to bring their perspective and have these very specialized dialogue, very thoughtful dialogues about the benefits of putting down your own biases, not passing judgment about the behaviors or what we thought was considered sin and not a sin, but focusing on the problem itself. what was in black and white were the numbers. We had high numbers of HIV in our communities. We knew that in the South, most individuals were connected to a faith-based institution. We historically have received in the South most of our action and planning and social justice has occurred in the faith community. And so using this type of language within our gatherings helped to sort of soften the speak and the understanding from those representatives within the faith, as well as help to get buy-in and support from those community agencies that were not all into faith. And so we were able to appreciate and value what each entity brought, understanding that our goal was focused on trying to get that healthy youth and keep that healthy youth safe in a preventive way. And if someone was HIV positive, keep them healthy and around. So that was our focus, and that's how we always did it.
Awesome. They asked someone who had a question around, well, first of all, great comment, so congratulating you all on removing that, addressing that barrier of the IDs, which is often a huge issue that we hear about throughout the country. They wanted to know if you, if there was any opportunity or inroads to sort of replicate that policy change from a local health department level to a state health department level, if you've heard of that happening sort of with Tennessee State Health Department, or if you had any commentary on that.
You know, I'm not clear. I don't have a lot of knowledge about if this presents as a barrier for other communities or other cities within Tennessee. I think that's great. I'm glad someone brought that up, and it's certainly worth checking into. We do partner with our state health department in Nashville because they sort of distribute most of the funding that comes, and so we have a nice working relationship with them just because they have lots of resources to support many of the key players that come to the table. And so I'll definitely take that back to them and just see, because I do believe that it's something that can be replicated in other communities. It's just a matter of having the discussion, first identifying if it's a problem, and having the discussion and getting those key stakeholders to buy into it and make the tweaks and train the staff.
Yeah. Rolling back to that earlier question around the SMILE graduates, there was a question around sort of what does engagement look like for Black MSM patient communities? What sorts of roles do they have on the CTP coalition?
So we have several subcommittees that we're refining now, but especially we've done some work with our BAL community. We've been privileged to have some pilot funds to help us do some very interesting things in our community around testing and linkage to prevention services and also linkage to care. And from that work that we started a couple of years ago, we've sort of built this cadre of young Black MSMs who are excited to be able to become advocates within their own community. And not all are HIV positive, and they are starting to buy into the notion that they don't have to be HIV positive. Unfortunately, there is this, and I'm sure that you've heard it, and I'm sure that many of us on this call have heard it, that many men who have sex with men will ultimately become HIV positive, and so there is this fatalistic type point of view that I may as well just live how I want to live, do whatever I want to do because I'm going to get it anyway. And so we've sort of seen this mentality shift. We've seen this change a little bit from some of those individuals that we engaged on a fun level, but it was a purpose level. We engaged them on a fun level. We built their capacity around the epidemic within the community. We talked about the resources that were there to protect them from actually becoming positive, such as PrEP and some of the other things. And so we have invested in these youth that now say, I want to do a little bit more within the community. How can I do that? There are a few PrEP protocols that are coming, and we've just received some funding to scale up PrEP within our community, and we now have the director of that new protocol who's going to participate on our community coalition, and we will develop a subcommittee that will become its own planning body around how to reach these young Black men who have sex with men and tell them about the different prevention methods and help them to guide some of our activities and our policies and practices and programs for HIV acquisition and prevention or reducing that. So we're excited about continuing this work in our community with those cadre of young Black men.
Really great initiatives coming down the pipeline. And speaking of prep, for the last question, we have a participant who sort of loves the work that you're doing with the with not just faith-based cohorts, but also with schools. And they had some questions around opportunities for prep access, or prep education, rather, happening at the schools that you were engaging, if you had any feedback or comments on that.
So we have 4 school-based health clinics that was an actual SDO that we started maybe halfway through our coalition building, maybe about 4 or 5 years ago. And the way we sort of built got the buy-in and support from the superintendents and also the health directors and the HIV directors at the HIV community programs at the schools is that we would build in educational forums and programs and talks around National Observance Days. And we'd also survey the youth to find out if they were only listening to this information because we were bringing it and then we were giving them trinkets and handouts, or was this something that was beneficial to them. We had the data that said that they had the highest rates of STDs, highest rates of chlamydia and gonorrhea, and so we knew that we needed to do the education and training, but we wanted to know from them, why is it that they were participating in mass testing that would occur on National Observance Days? And we found that through some of that, those surveys, is that they had a genuine interest. They were concerned about their own well-being and some of their peers, and they wanted to be a part of the change. And so having these advocates there on site at the schools actually helped to sort of springboard what we were implementing. We didn't go in and do the talk ourselves because they told us we were too old. We talked way too slow. Our answer to that was to implement a new practice where they will become the HIV educators and advocates within their community. They develop these vignettes around prevention, and we were able to then get our foot in the door and do active testing, active education, not just in those 4 school-based health clinics, but the word began to spread throughout the district, and we began to get calls from various schools saying, we need this, can you come, can you come? And so multiple times on 1 or 2 days, especially around National Observance Days, I or some of the coalition members would set up times to go and do these educational forums. We would use and play the vignettes that were recorded from those youth to help reach them on another level, and then we would take the results back after we partnered with the health department to do HIV testing and STD testing, and we provide those results back to our community at the schools. And what we found is now that PrEP has become more in our community, we're hearing more about it, our youth are getting the wind about it. We are building any educational forum that we have. Last week I participated in a health conference for our youth, and we talked about prevention and what that would look like for HIV. We also talked about long-acting birth control for young girls and what that would look like, trying to work on the pregnancy rate that is a little bit higher than what we'd like for it to be in our community, but also talking about ways to not just use a condom to prevent HIV, but what can we do for how can we use PrEP? And what we're planning to do here in Memphis is we've just received a new grant that will focus on the injectable. So we even talked about that and what that would look like and the benefits of having the injectable versus the pill, and how that would hopefully turn these numbers around in our community.
That's awesome. There's a lot going on there. It's like Monday, wow. Like all these initiatives. So we're rounding out the hour, Andrea. We want to thank you so much again for sharing what you're doing, which is really model work. We're excited to work with you and feature you in His Health. Participants, we want to thank you so much for joining us as well. And a little bit of forecasting. Our next webinar is scheduled for May 31st. It's entitled Spotlight on Sustainability, Leveraging Health Systems Reform to Maximize Sustainability and Access to Services, with a special bend on programs that are servicing Black MSM and that are also run by communities of color. So we'll hope that you will join us. Andrea, thank you again, and we'll be following up with our survey, our thank you email, and this PowerPoint for your reference in the coming days. Thanks again, everyone, and have a good one. Bye.
Thank you.